You see a lot in the ER: violence, overdoses, heart attacks, grief that tears people apart, relief that glues them back together. But every so often, something walks or wheels through those doors that doesn't fit what you know, doesn't obey logic, doesn't leave when the shift ends. That night was quiet until it wasn't. We got a call from County Psych about a male patient, 28 years old, known schizoaffective disorder, no drugs, no trauma. But something had changed. He'd started pacing, then laughing, then dropped to the floor in a full tonic-clonic seizure. EMTs reported prolonged seizure activity, uncontrolled muscle contractions, and postictal confusion on arrival. They dosed 2 milligrams of midazolam en route but reported no improvement. We prepped room 3. He came in restrained and still twitching, his limbs jerking rhythmically, his eyes wide open but unfocused, rolling. I moved in to monitor vitals, BP crashing, HR spiking, oxygen in the low 80s. We started him on high-flow oxygen and Ativan Ivor push. I held his head still as Jamie placed leads and the attending reviewed meds. Then it started. Laughter. It wasn't a soft chuckle or an involuntary sound from diaphragm contractions. It was sharp, guttural, erratic. It bubbled up from his chest and filled the room. The patient was still mid-seizure, body locked in rhythmic motion, but the laughter, it didn't stop. It was too long, too strange, like he was gasping between punchlines we couldn't hear. I've worked plenty of seizures. Postictal crying? Sure. Moans? Yes. But laughter? Sustained, conscious-sounding laughter? No. And then came the blood. A slow trail leaked from his right nostril. A few seconds later, the left. Then, strangely, from his right ear. No signs of trauma. No skull fracture noted. But the pattern was consistent with intracranial pressure, possibly a hemorrhage. We ordered a stat CT, but his pressure was already plummeting. The laughter grew quieter, but his mouth was still wide, jaw clamped into a grin so tight it began to tear the skin around the corners of his mouth. His eyes locked straight ahead, no blink. It wasn't a seizure anymore. It was something else. At that point, he began to desaturate rapidly. SpO2 dropped into the 60s. We had no choice. We intubated. I remember watching the laughter cut off mid-sound the moment the tube passed his cords. Airway secured. No more vocalizations. The room was silent except for the rhythmic whoosh of the ventilator. That silence, it was louder than the laughter. A few minutes passed, and then, nothing. He coded. We initiated ACLS. Compressions, epi, defib, the whole protocol. 17 minutes. We tried. God, we tried. But we lost him. Time of death, 12:08 a.m. As I removed the intubation tube and cleaned his face, I froze. His lips, despite everything, were still stretched in that impossible grin. The muscles had stiffened, jaw locked so tight it resisted any repositioning. Rigor sets in fast sometimes, but this felt unnatural, like he died smiling. We bagged and tagged, sent him to the morgue with notes on probable intracerebral hemorrhage, possible AVM, pending full autopsy, but nothing explained the laughter, the grin, the bleeding pattern with no trauma. The next day, the attending reviewed the CT report: diffuse subarachnoid hemorrhage, massive midline shift, brainstem compression, but no aneurysm, no prior head injury, just sudden spontaneous death. I stayed late and asked the psych nurse who accompanied him what his last words were before the seizure hit. She looked at me and said, "He kept telling us a joke was coming." I didn't ask what the joke was. I never will. Hello friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare. We don't talk much about superstitions in the ER. There's just no time. Between the beeping monitors, the trauma alerts, and the endless flow of patients, you learn to push the strange and the unexplained into a mental drawer, labeled "deal with it later." Most of us never open that drawer again, but every once in a while, something slips out, and it sticks with you. I remember the first time I heard about the hallway clock from Lorraine. She was one of our senior night shift nurses. Quiet, straightforward. The kind of nurse who didn't waste words or entertain nonsense. If a code ran long, she stayed behind to help clean the room. If someone needed coverage, she never hesitated. Lorraine was clinical to the bone, but not unkind. She just didn't believe in fluff. That's what made her story so strange. It started with a patient in Trauma Bay 2, an elderly man, late 80s, brought in by EMS after a fall at home. Hip fracture, stable vitals, some confusion. Pretty routine, all things considered. Lorraine and I were assigned to his care that night. I handled the IV access, she started the assessments, and we had imaging ordered within 20 minutes. Around 1:47 a.m., while waiting on radiology to wheel him out, he coded. No prior warning, no arrhythmias on the monitor, no change in breathing pattern. Just a sudden flatline on the telemetry, followed by the alarms. We started compressions immediately. Full code, multiple rounds of epi. Airway secured. We worked him for about 20 minutes, but he never came back. Time of death was called at 2:08 a.m. Lorraine wrote it down as always, then went out into the hallway to call the family. I stayed behind to clean up. When she returned, she looked pale, unusual for her. Clock stopped, she said quietly, gesturing toward the digital wall clock in the hallway. Right at 2:08, it just froze. I followed her out, half expecting her to be wrong or exaggerating. But sure enough, the red LED display on the clock above Trauma Bay 2 was frozen. 2:08, completely still. No blinking colon, no second count, just dead. 5 minutes later, it flickered once and started ticking again like nothing had happened. I told her maybe it was an electrical glitch. She didn't argue, but her silence told me she didn't buy it either. I shrugged it off, until it happened again and again. Always when Lorraine was assigned to a patient who passed. Always that same clock. Always frozen at the exact time of death, and always restarting a few minutes later. I started paying closer attention, quietly, without saying anything to the others. Every time a patient on Lorraine's care coded, and we couldn't bring them back, I'd glance at the hallway clock. And sure enough, it would be still. Not broken, just still. She noticed me checking once, months later, after a cardiac arrest in Bay 4. Middle-aged male, massive MI, came in with crushing chest pain, then coded before cardiology even got to him. Lorraine was with him that night too. Clock stopped at 3:26 a.m., restarted at 3:31. As we stripped off our gloves and tossed the soiled linens, I asked her softly, "You notice it again?" She nodded. Every time. I didn't press her. She wasn't the type to offer more than she felt necessary. But something about the way she stared at that clock, it felt like this wasn't just a weird coincidence to her anymore. I started checking the logs, quietly, late at night when the ER slowed down and the charge nurse wasn't hovering. I looked at time of death entries for every code Lorraine had been part of. I cross-referenced them with clock reports from facilities, maintenance logs, incident requests, anything that would explain the malfunctions. There was nothing. Not even a service call. No batteries were changed. No software updates. No maintenance requests filed. The clocks never failed unless Lorraine's patient died. Then, and only then, they'd pause. Precisely. One night, after a particularly rough shift, a pediatric drowning case, we were both sitting in the staff lounge, drained. I asked her directly, "Have you ever timed it?" She looked at me, eyes tired but sharp. They always stop for 5 minutes. Not 4. Not 6. 5, on the dot. She sipped her coffee and stared into it for a long time before she added, "My grandma used to say the soul needs a moment to catch up. Like the body stops, but the spirit lingers, just for a little while." Then she stood up, tossed her cup, and walked out to start restocking crash carts. That was Lorraine. No drama, no ghosts, just facts, procedure, and 5 minutes of stillness. She retired last year. I took her shift after she left. Funny thing is, since then the hallway clock never froze again. Not once. We've lost patience, of course. This is the ER. Death doesn't wait. But the clock keeps ticking now. One of the newer nurses joked that maybe Lorraine was the one stopping it all along. I didn't laugh. I still see her sometimes. She drops in to say hello when she's picking up supplies for the nursing home where she consults now. We never talk about the clock. But every time I walk past it, I glance up. And every time it's ticking, steady as ever. Still, I can't help but wonder. What if it was never about the clock? What if it was about her? What if something followed Lorraine? Or worse, what if something left when she did? I've worked ER for 16 years. Enough time to know the difference between burnout, sleep deprivation, and actual fear. And I don't scare easy. I've been covered in blood, screamed at, shoved, and watched more people die than I care to admit. But radiology? That place has a reputation. Not just among new hires or the superstitious. Even the seasoned ones like me. We avoid it when we can. At night, radiology is technically closed. The main lights are off, minimal staff, usually just a tech or two for emergency CTs or X-rays. The area runs on motion-activated lighting, supposed to save energy, but there's a long stretch of hallway between ER and radiology that never quite feels right. You can be halfway down and suddenly hear something metal shift, like a gurney being moved or the soft swish of curtain tracks, even when no one's there. Now, I'm not talking about creaky pipes or drafty vents. I'm saying that multiple people, nurses, techs, transporters, have reported seeing something. Always the same, a tall black mass about the size of a person, moving too quickly to be natural, sometimes seen between curtains in the imaging rooms. It's always peripheral. You never get a good look, but it's fast and it moves like it knows you're watching. It's almost become a joke on night shift. You want a CT? Better make sure the radiology shadow isn't using the machine. That's how we cope, but nobody lingers there alone. I didn't used to believe in any of that. I thought maybe people were overtired. Maybe someone saw a janitor or a late shift tech and their brain filled in the rest. Until one night, about 3 years ago, we had a code stroke roll in. Woman in her 70s, sudden onset aphasia, right-sided weakness. Classic signs. I wheeled her up myself for a stat head CT. Radiology was unusually quiet. No tech in sight. I called out, no answer. But the system was on, and the doors to the CT room were unlocked. I parked the stretcher just outside the scan bay, and was about to call central imaging again, when I saw movement behind the curtain across the room. It wasn't subtle. It was like someone took a step forward, just enough that the fabric shifted. But there were no footsteps, no sound, just presence. My first thought was a tech messing around, maybe hiding or changing. I called out again, nothing. Then I noticed something strange. No ambient light behind the curtain, none, even though the rest of the room was softly backlit from the monitors and wall panels. This area, it was black, like light stopped working behind that curtain. I told myself to get over it. I stepped in, pulled the curtain back. There was no one there. But what stuck with me, the curtain was warm, not hot, but warm, like someone had been standing behind it, just seconds before. I got that CT done, fast, got her back to the ER and wrote it off. I told myself it was stress, just a long shift, but the week after that, something happened to Marta, one of our newer night nurses. She'd been sent to radiology with a kid who had a head injury, just a toddler, low impact, but protocol still called for a scan. Tech was delayed, so Marta waited in the corridor just outside the scan bay. She had the mom and the kid on a stretcher, both calm. Then Marta screamed. When we got there, she was collapsed on the floor. The child's mother was crying, and the tech who had just walked in was trying to rouse her. Marta came to within a few minutes. No seizure activity, no trauma, but she was pale and shaking. She wouldn't speak for the first few hours, just kept saying, "It moved toward me. It lunged." When she finally gave a full account, her story was unsettling. She said the moment the lights in the corridor flicked on from her movement, she saw it, a shadow, the height of a man, darker than the dark. It darted from one side of the bay to the other, behind the curtain, and then it charged straight at her. She said it didn't make a sound, but she felt the air push back, like it took something from her. Hospital admin got involved, reviewed the security footage. No footage inside the bay, HIPAA, but the corridor cameras, they showed Marta leaning against the wall, chatting with the mom and then recoiling hard, like she was shoved, but no one was near her. No one came in or out for over 7 minutes. The tech hadn't arrived yet. That part's confirmed. After that night, she requested a transfer today, and she got it. Never stepped back in that hallway again. The rumors only got worse. One night, facilities was called in to check a malfunctioning CT machine. Apparently, it kept running calibration cycles on its own. When they pulled the logs, they found entries for scans at 3:12 a.m., 3:14 a.m., and 3:17 a.m., all under phantom patient IDs. No accompanying order numbers. The tech swore no one accessed the system at those times, and the room was locked. We've had priests come in before, quietly, not announced, not official, just a few spiritual care staff who walked the hallways with someone in plain clothes. And after that, radiology was shut for scheduled maintenance for 2 days. When it reopened, things got quieter, for a while. Still, no one likes going down there alone. And the older nurses, the ones who've been around long enough, we all seem to share this unspoken understanding. If something is moving behind those curtains, don't open them. Don't call out. Just walk away. Whatever that thing is, it's not looking for help, and it knows who sees it. handled violent psych patients, drug-induced psychosis, dementia cases, just about every type of altered mental status imaginable. So when the call came through, about an elderly female in respiratory distress, possibly delusional, I didn't think twice. We were used to confusion in the elderly. Half the time it was low sodium or a UTI. She arrived around 2:30 a.m., brought in by her neighbor. EMS said she lived alone and had collapsed in her kitchen. They'd found her conscious but nonverbal, whispering or muttering something over and over. She was maybe late 70s, skin pale, lips dry, eyes unfocused. But what caught me first was the sound, her voice. Deep, not gravely from age, but wrong, resonant, too deep for her frame. It was low and constant, like a chant on repeat. I leaned in to hear better, and that's when I noticed it wasn't English. It wasn't Spanish either, and I'm fluent in both. Our charge nurse, Maria, is Catholic and fluent in Latin from her years in parochial school. Her face drained of color when she listened. She stepped back and whispered, "She's praying in Latin, but it's not a prayer I've ever heard. And the grammar is strange." At that point, the patient began to clutch her side, abdominal pain. Her vitals were erratic. BP 171, 112, heart rate spiking to 120, then dropping. We paged the attending and started labs. While placing her IV, I was close enough to hear her muttering clearly, "Mortem venit. Porta est aperta." Maria translated it. "Death comes. The gate is open." Half the room went silent. Now, we don't entertain superstition on our shift, but I'd be lying if I said the energy didn't change. The temperature didn't drop. But the feel of the room did, like a pressure behind your sternum, tense. Everyone felt it. She suddenly started seizing, full tonic-clonic. We administered Ativan, stabilized her airway, and moved her to a critical care bay. While we were prepping her for a CT, her muttering resumed, only this time louder, rhythmic, almost like singing. The lights didn't flicker, no dramatics, but what happened next doesn't sit right. Even to this day, she turned her head, eyes still closed, and called out in that same too deep voice, "He is already here, watching," and then she smiled. Wide, unnatural, her teeth were clenched tight, but the sound kept coming, as if her throat didn't need her mouth. The ER doc called for a psych eval, just in case. We got in touch with security, just protocol. But Maria pulled me aside and said we needed to page the chaplain, or a priest. Now normally that's for last rites, but she insisted. "Something is wrong," she kept saying. "Not just medically. Wrong. The chaplain on call was busy at another hospital, so we ended up calling a local priest, who occasionally assisted with trauma support. He arrived half an hour later, still in his street clothes. Quiet, respectful. Didn't even question it when we explained. We moved to the room. By that point, the woman had gone into some kind of altered state. Her pupils were blown wide. She wasn't responding to stimuli, but her vitals were still present. The muttering continued, guttural, fast, erratic. The priest stepped to her side and began a simple prayer. Nothing dramatic, just "Our Father," spoken softly. She suddenly jolted, eyes open, fixated on him, and then she spoke in perfect, articulate English. "You shouldn't have come." The voice wasn't deep anymore. It was layered, like multiple voices speaking at once. I've never seen a priest freeze like that. He composed himself and continued the prayer, now placing a hand gently near her shoulder, but not touching. The moment he got to deliver us from evil, she let out a long guttural breath, not a scream, just the release. Her chest rose once, then nothing. We called the code, tried to resuscitate. Compressions, epi, defib. She never came back. Time of death, 4:14 a.m. What shook us wasn't just that she died, it was what happened next. The moment she passed, the priest stepped back, looking pale, and said quietly, "I don't think that was all her." Her labs came back normal. No drugs, no infection, no clear neurological issue. CT showed mild atrophy, consistent with age. Nothing to explain the seizure, nothing that would explain the voice, or the language, or the behavior. We filed the report, documented accurately, no embellishment, but we all knew we'd seen something that didn't fit the books. To this day, when a patient comes in mumbling nonsense, I listen closely, just in case it's Latin. Thank you so much for watching and being part of this growing community. Your support means the world to us, and it's what keeps these creepy, fascinating, and sometimes comforting stories alive. We'd love to hear from you. If you've experienced something eerie, unexplained, or deeply moving, feel free to share your own story in the comments below. You never know, your story might be the next one featured. And if you haven't already, don't forget to subscribe, like, and share to help keep the chills coming. We couldn't do this without you. See you in the next one.